Hello and welcome to the Microbiome Medics podcast. I'm Dr Siobhan McCormack.
And I'm Dr Sheena Fraser, and we're your co-hosts.
We are both GPs and lifestyle medics with a shared passion for microbiome science, and we have spent the last 5 years deep diving into the world of the gut microbiome.
We've been analysing the evidence, appraising the studies, speaking to the experts, and writing the Gut Microbiome for Clinicians e-learning course for the BSLM Learning Academy.
We have discovered that the gut and other human microbiomes are pivotal to every aspect of your health and physiology, and the pillars of lifestyle medicine hold the key.
So in these Microbiome Medic podcasts, we'll be covering the basics, bringing you the latest research and talking to the experts on all matters microbiome.
We'll be translating the evidence and packaging it into actionable, bite-sized chunks so that you can harness the power of the microbiome to improve your own health and that of your patients. Hello there, and a very warm welcome to another episode of Microbiome Medics podcast. I am Dr Siobhan McCormack, and I'm joined as always by my microbiome buddy, Dr Sheena Fraser. This is our third episode on the topic of the gut microbiome and cancer, and here's a quick recap. In episode 1, we discussed what cancer is, the role of the gut microbiota in cancer prevention, and the vital contribution of nutrition in providing microorganisms living in the gut with the raw materials to provide numerous beneficial metabolites. Episode 2 looked at the role of the gut microbiota in an individual's response to different types of cancer therapies and how this knowledge might be harnessed to improve cancer outcomes. If you've missed these episodes, you might choose to go back and listen from the beginning. Hey, but now you're here, you are very welcome to stay, so why not pull up a seat and join us, because Sheena and I really want you to meet this guest. We're joined today by Professor Robert Thomas. He's an NHS Consultant Oncologist at Bedford and Addenbrooke Hospital, and he trained at the Royal Marsden, and he's accumulated many years of experience managing patients with a wide array of cancer therapies, including chemotherapy, radiotherapy, hormones, and biological targeted treatments. But what makes this doctor unique is his many other professional roles. He is Professor of Sports and Nutritional Science at the University of Bedfordshire. He's a teacher at Cambridge University, but he's also an active science researcher with a keen interest in the gut microbiome and cancer. Currently, he heads up the Lifestyle and Cancer Research Unit. Now, this unit designs and conducts government-backed studies evaluating the impact of exercise, diet, and phytochemicals on cancer and other chronic diseases. And more recently, he's been researching lifestyle approaches to recovery from COVID-19. The research unit collaborates both with universities in the UK, such as Cambridge and Glasgow, and the USA, and to date, it's published more than 100 peer-reviewed scientific papers, and I'm sure we'll be hearing about some of these today. Professor Thomas is also patron to 2 cancer support charities and acts as advisor to Macmillan, and remarkably, for such an incredibly busy man, in 2020, he somehow found the time to write the UK best-selling book, How to Live. This is a lifestyle guide for anyone out there wanting to improve their health through evidence-based lifestyle approaches. I've read it, I love it, I learnt loads, and it's a book I highly recommend. I'm guessing by now you won't be surprised to hear that Professor Thomas has received several awards, including the British Oncology Association Oncologist of the Year. Look, I could go on, but we're going to run out of time. Plus, I want to spare his blushes. So let's get cracking. Sheena, Professor Robert Thomas, hello and welcome.
Lovely. Thanks, Shiv. That was a great intro. And yeah, I'm really impressed to have Rob in our podcast today. It's really exciting for me, especially back in 2018 when I hadn't really heard of lifestyle medicine before. I went to a conference and I attended a lecture by Professor Robert Thomas. And it was one of the most interesting lectures I'd ever been to. He introduced me to the concept of the gut microbiome and why it was so important in our health. And I came away from that lecture and that changed my life. I started learning and researching, and that was the start of my passion and my interest into the gut microbiome and human microbiomes in general. So, Rob, I've got to thank you for that. So thank you so much for what you've done for me. But I'm really interested to hear from you. And I'm interested to know, because you were a bit of a pioneer at that time, How did you actually get to that point? When did you start your interest in lifestyle medicine and microbiome science?
Well, again, thank you for being on the show. I've been around for quite a long time now. I'm not young anymore, so it's all those sort of accolades sound very impressive, but it is over a long period of time. And I suppose in the early days, when I first became a consultant, I was more involved in how to empower patients to help them make decisions about their different treatment options. And in those days, it was about patient information, developing videos and filofaxes so they could understand what's going on. That seems routine now, but 30 years ago it wasn't. So now, thankfully, it is routine. But obviously, going on from that, patients now say, well, look, what can I do to help myself? How can I prevent my cancer coming back? What advice do I give my children and relatives who are worried about cancer? So there was a natural progression from patient empowerment now over to nutrition and exercise, I suppose.
So tell us a bit about your research and the bits of your research that have really, really enthused you over the last few years.
Well, as a research unit, we do conduct many what we call mainstream studies of new drugs. We were very heavily involved in new radiotherapy regimes and Herceptin in the early days, etc. But my personal interest and interest of others I work with in the university and the hospital is to try and find the evidence to support lifestyle and nutritional advice. I mean, it all seems very common sense to tell people to eat well. But not everyone believes that. In the early days, the dietitians were very much against any sort of nutritional advice. They think they sort of had the domain on that. So you had to do the trials to show that exercise and nutrition has an influence on, mainly because I'm an oncologist already, mainly on whether it can enhance the response to cancer treatments, reduce the toxicities. So the research was aimed to find the evidence to convince colleagues and to convince fund holders, essentially. So I can go on to some specific examples if you like.
Yeah, because I'm really interested in how you managed to convince the dietitians, because I know that obviously the dietitians have their own policies and protocols and procedures, and that's been something that I've been interested in recently when I've had patients who have been told to have high fat, high sugar diets when they have cancer. And for me, that's really counterintuitive when the high fat and the high in sugar is going to encourage the wrong type of microorganisms in your gut. That concerns me when you already have a cancer and likely have dysbiosis of your gut microbiome. So tell me what you did with your dietitians.
We had a lot of, for example, telling patients to eat less processed sugar does seem very logical, but that was actually blocked by the dietitians. They were saying if I was giving a talk, there was always a dietitian who'd stand up in the back and say, you're talking nonsense. So the first thing we did was an evidence review, looking at that. There's loads of data out there to show if you have more processed sugar, you're more likely to get cancer. And even more likely to get cancer relapse, actually. So it's to summarize the data. We did a series of publications. So when we got an obstructive colleague, we were able to put the evidence in front of them and say, please read that, and then come back and have a chat. They usually came back and saying, I'm really sorry. Yeah, there's clear evidence. Then coming on to the microbiome, again, people were saying, well, it's irrelevant. But lots of research was beginning to come through showing that biological treatments work better if you have a better microbiome, you have less toxicities, you're less likely to end up in intensive care. And it was again about collecting the data and presenting it to your colleagues and in international conferences. And on top of that, we did some studies looking at reducing sugar amongst our staff and looking at happiness scales and absenteeism. And we were able to present that to our managers and say, look, instead of having piles of sweets on the nurse's station, we should have healthy foods because it's cost effective and staff is having. So it's about, presenting the data to your colleagues in a way. The next step, I suppose, it's actually got more mainstream now. Even the president of ASCO, which is the largest cancer conference in the world, stood up and said, we need to do more research into the microbiome and cancer. There's a large ongoing project in Cambridge University, which is looking at microbiome signatures in response to different biological agents. And this is a major project with lots of clever people and PhDs and things. So it is becoming more mainstream. It's usually the early days is where the problems lie. And the next stage in research is not just to identify a link between a poor microbiome and an increased risk of cancer and toxicities, is to say, what can we do about it? We need to develop prehabilitation programs so people can improve their microbiome before treatment starts, and that's when it gets more research based. And at the moment we did 2 trials in patients with COVID. I know it's not directly related to cancer, but COVID was a major disruption of cancer treatment. So we felt it was good to be involved in that. And we gave patients an intervention with prebiotics and probiotics in capsule form, which intensifies the intake of bacteria and prebiotics. And we showed very significant improvements in symptoms of long COVID, many of which are similar to the symptoms post chemotherapy and biological treatments. We're now going on to do a intervention of a probiotic with the COVID vaccine to see if it enhances the effectiveness and reduces the toxicity of the vaccine. Again, people are being advised to take probiotics or not, but there's no hard randomized data to support that, and that's what we're looking for. And the latest study, which is gone, hopefully we had the ethics review this afternoon, is to look whether an intervention to improve gut health for prostate cancer would slow the progression. And there's lots of, in your last 2 podcasts, there's probably lots of theoretical reasons how an improved microbiome could make the body more armed to fight cancer, or if you've got an existing cancer, to reduce the chronic inflammation which drives the cancer cells to replicate faster. And that's a really exciting study. It's called the Your Phyto study, and it's using the Your Gut Plus probiotic with Your Phyto and measuring against PSA, urinary symptoms, erectile function. And also we've thrown in grip strength because we feel, which is a very good marker of overall well-being. And we feel that if you improve your microbiome, all of those things should improve. But of course, it needs to be established in a statistically evaluated study.
So you've done a lot of interesting research into polyphenols in how they enhance the gut microbiome, and obviously your prostate cancer study is another example of that. Did you say polyphenols were going to be one of the things that you're using to enhance the gut microbiome? Is that right?
Exactly. In 2013, we looked at a double-blind randomized trial looking at a supplement which had broccoli, green tea, pomegranate, and turmeric. And in those days, these things were quite novel. Now, people taking turmeric supplements seems to be routine. And the reason why we did it is polyphenols have a number of ways which could help you fight cancer. They reduce inflammation, they reduce oxidative stress. I don't like calling them antioxidants because they enhance the antioxidant process rather than our direct antioxidants. They have direct anti-cancer properties by helping enhance apoptosis and reduce proliferation. Back then, we didn't mention the effect on gut because we didn't really think that was one of the mechanisms. Since then, we realize that these foods, probably one of the main benefits they have is acting as prebiotics and reducing inflammation within the lining of the gut, which improves the gut microbiome. So that sort of come out from that study. And that's why in the latest study we're doing, we're now using probiotics to see if we can further enhance that mechanism of benefit.
Okay, and so you're using supplements and probiotic supplements and these polyphenol supplements because in the study group, it's easier to then make sure that you're getting the same kind of dose in to patients rather than using the whole food equivalent. Is that right?
Yeah, well, within research, you need to quantify the interventions. So it's not impossible to do pure dietary studies. In other words, you in one room have to carry on with a normal diet, and you in another room, please can you eat, freshly squeezed pomegranate, a tablespoonful of turmeric, a bowl of broccoli, 4 cups of green tea. But the compliance is so poor in those studies, you never really get statistically valid results. We know that 70% of men with prostate cancer, for example, do like supplements, do take them. We know that women who have symptoms related to their hormones, again, about 70% try supplements. So it's something which is already out there. In the first study we did, it was called POMI-T, which is the supplement, and we randomized that against placebo because they weren't so commonly taken back then. But now they're very commonly taken. So we wouldn't be able to recruit men if we randomized a polyphenol supplement against placebo, because there'd be so many people already taking them, it wouldn't be statistically valid. So that's why we've had to say to everyone in the study, right, stop everything you've got. We will give you a polyphenol-rich supplement to everyone, and everyone takes the same one. So the scientific committee has developed, well, they looked at what the evidence is, that most of it was from the previous POMI-T study, but they've added certain ingredients. They've added ginger, cranberry and things, all of which have independently shown effects on prostate cancer and urinary health. So that creates a level playing field. And on top of that, we then randomized the probiotics or not. Now, of course, and we're hoping that people don't take any other probiotics. Now, that way, you can then really find out whether a strong probiotic, which we know from previous studies using it, will enhance your gut health. Will that have an effect on symptoms and PSA? And we're really excited because everyone's talking about gut health and prostate cancer now. But this would be the first study which would show, hopefully, that an intervention would help. Now, after the study, once we've got that data, patients then have a choice. They can say, well, I know gut health is really important from this study. I can go out and eat kimchi. I can reduce sugar. I can exercise, all the things which helps gut health. Or as well as that, they might choose to take a supplement. But what we're doing as researchers is finding the information. What they do with that information is entirely up to them.
Yeah, I think that's fair. And it's good that people have a choice. Supplements, of course, are very, very expensive on the whole, and whole foods are much cheaper. It's much cheaper probably to have your 4 cups of tea a day and your teaspoon of turmeric than it is to get it in a supplemented form. So, I mean, obviously, it would be lovely if people were to use these natural polyphenols in their day-to-day lives anyway.
Absolutely.
So your unit has stopped using prophylactic antibiotics for chemotherapy. You've mentioned this before. I was just wondering whether you could tell us a little bit more about that, because we've mentioned the impact of antibiotics in our previous podcast. And it's really interesting to me that your unit has started doing this, because I don't know if that's something that is common to all oncology units at the moment, or whether this is a bit pioneering on your part.
No, I think it's a trend which is across the country, to be honest. It was mainly that, you might prevent a couple of infections, but more likely by taking so many antibiotics, you're actually then, when they did get an infection, it was more likely to be a more aggressive antibiotic resistant type. So now, whether that was directly related to gut health is hard to say. I think probably yes, because if you give antibiotics when you don't really need them, all you're doing is damaging the gut health, and that would make that person more susceptible to an infection, not only in the gut, but elsewhere in the body. So, yeah, I mean, it's interesting that's now routine that we don't do it. More to the point, when we now give biologicals, and, over the last 5 years, there's been an enormous shift in what oncologists do across the world, whereas even up to 5 years ago, it was all chemotherapy, and hormones. I would have to say, even for, say, metastatic breast cancer, which I also treat, the first choice, if they're estrogen receptor positive, is to go on to, more specialized hormones rather than chemotherapy. If they're HER2 positive, or even now triple negative, you're going on to biologicals. So most patients will have a biological treatment as part of their either adjuvant or metastatic treatment. Now, we know that biologicals depend on a healthy immune system for them to work. And part of a healthy immune system is to have a good gut health. So we're actually, and I'm not sure if this is particularly universally adopted, but certainly in our centre, we're sitting down to patients and saying, look, this is not just, go for a run, it's good for you. This is really important advice. You need to listen to us very, very carefully, because your chance of responding to these treatments are going to be 40% better if you have good gut health. So we really spend a lot of time, explaining what gut health is, how they can help themselves, with all the things I'm sure you shared already in your podcast. And on top of that, we're saying to other doctors and ourselves, look, if you need to use an antibiotic, really make sure it's absolutely, almost life-threatening. If you need to use a anti-indigestion or omeprazole or lansoprazole, try to get patients off. There's so many patients just take anti-indigestion medications for ages and they don't really know why they're taking them. Try to come off that. Non-steroidals. So all these drugs which we dish out willy-nilly, are damaging gut health. So actually, you've got to think. So it's not just about the diet; it's about what we're prescribing as well.
Mm-hmm. And as a GP, I'm quite often chatting to patients just when they're given their diagnosis to offer them support and offer them care at that stage. And like you, I've started having these conversations with them about the importance of their gut health before treatment, before they start their chemotherapy. And so, like you, I've been quite proactive. I'm interested to hear what your specific advice is. You've mentioned coming off medications that might be damaging gut health. You've mentioned regular exercise. What is your current advice diet-wise? And do you have anywhere you point patients to access in terms of good resources to help to improve their gut health with nutrition?
There's a website, keep-healthy.com, which has got a good summary of things. The British Society of Lifestyle Medicine website has got good resources. But they often want a one-to-one chat about it, and I always say, look, start the day. You've had a rest overnight. You've fasted. If you can extend that a little bit by going for a run in the morning or a walk first thing, I think is the best thing, because we know that overnight fasting, it has anti-cancer properties. Possibly one of the ways it does that is by improving your gut health. So start the day with, if you can, a brisk walk, another 20 minutes, or a run if you're more physically active. And then the first meal you should have is telling your body what's inside. So if you have, if you have Frosties with extra sugar on top, which you'd be surprised how many. Well, you're being a GP, you're probably not surprised.
I've seen it all.
People, or anything like that, or even granola. I mean, what's granola? It's just a pile of sugar as far as I can see. So start the day without any processed sugar. So nuts, fruit is obviously fine. It's blackberry season at the moment in my garden because I don't look after it very well. It's full of blackberries, so it's free organic superfoods. So pile the blackberries on, or fruit, any other fruit. If you're not gluten intolerant, things like Weetabix and stuff like that is okay, but many people get gluten sensitive as they get older. And have no sugar. So all slow release things, which then means you don't get hungry at 11 o'clock and then snack with something sugary. You can then go have another little fast up until lunchtime. I think that just in itself is probably the strongest advice. If you're exercising in the morning, it improves your circadian rhythm. It helps you sleep better at night. We know that people who have poor sleep patterns have worse gut health as well, because the gut is the motility of the gut is too much at night, so it doesn't give the bacteria time to sort of grow. Then going through the day, try to have with every day, try to have something with live bacteria. So for example, on a personal note, I go and I sort of buy some kimchi, which you just sort of put a tablespoon on with your lunch. It's quite expensive if you buy it, mind you. So if you can make it, if you've got the time and resources to make it, or sauerkraut, that would be better. I failed. But for example, I gave a talk in a prostate cancer group recently, and I said, look, don't listen to me, listen to this guy who makes his own kimchi and sauerkraut. So the first 20 minutes was how to make kimchi and sauerkraut, and that's what you should have every day. And as well as the prebiotics such as mushrooms, artichokes, beans. Try to swap meat, beans for meat. I'm not saying you need to cut out meat. Probably 2 or 3 times a week is optimal. For other meals, have things, beans, mushrooms, lentils. These are all excellent for gut health. And then patients sometimes get to me, but I have loads of wind and things when I do that. I said, yes, because your gut is in a poor state, and when you change, yes, it will ferment more and produce more wind, but you've got to work through that, and eventually that becomes the norm, eating those foods, and you don't get extra wind and things, and because your gut is in a better condition, and you feel better. You get slimmer, you feel fitter.
Fantastic. I think that's all wonderful advice, and yeah, I mean, it's really interesting, isn't it? People's starting point there's often quite a lot wrong with their lifestyle that, you can see why there's been, reasons for that cancer development. And there's normally been either a lot of stress, a lot of insomnia, a lot of chronic disease processes going on, likely to be a lot of inflammation there. So it's really interesting. It needs to be that very holistic approach, I think, as you say, need to look at all aspects of their lifestyle. Can I just ask, is there anything else that your unit does differently to other cancer units, do you think, that in terms of your lifestyle-based approach?
Well, fortunately and very reassuringly, cancer units are beginning to adopt some lifestyle measures now, mainly because of the big drives from the large cancer organizations like ASCO, who are pointing out the evidence that you really need to try and prehabilitate patients. But, some more enthusiastic than others. For example, we were very much involved in the exercise qualification for personal trainers, a level 4 program that personal trainers can do and get them experience in cancer. So it's called the level 4 cancer rehabilitation qualification. So we developed it. It goes nationally. We campaigned NICE. We worked with Macmillan, and we got it in NICE guidelines. For example, that if you start a hormone therapy for prostate cancer, you have to put people on a 12-week exercise program, because that reduces toxicity. So that's in NICE guidelines. So in theory, the unit could get fined if they don't implement that. So we do that routinely. Every patient gets referred to an exercise program. And we're very lucky that we've got Bedford University, who take on all our prostate patients and give them a very bespoke, individualized exercise program, which I have to say, that's probably unique. And, it's very disappointing when you work in other centres across the network and you say to people, where do you send your men for the 12-week program, which is in NICE and should be law, and 90% say, I don't send them anywhere. So I suppose it's not that we do things differently, but we do things hopefully for every patient. That every patient has to have, we looked at what they're on. If it's Zoladex for prostate cancer, they have an exercise regime. They see a dietitian. If they even a little bit overweight, because they're going to be very overweight, but they've had hormones for 4 months. We did a lot of studies about 5-6 years ago looking at side effects of hormones for women, well, mainly women with breast cancer, looking at tamoxifen, aromatase inhibitors. And we did about 4 randomized trials actually looking at differences between different brands of aromatase inhibitors and tamoxifen. And we learned a lot from that. And we learned a lot of ways women can help themselves if they have menopausal symptoms, such as mood, arthritis, hot flushes, which are the sort of main 3. And then more recently, I can't claim credit because it was actually someone from Japan who was found out about the POMI-T supplement, which is given over there. And they said, well, why don't we give this to women with menopausal symptoms who've had cancer? Because there's some evidence that turmeric helps joints and, gut health, and hot flushes are linked, etc. We know that could influence. And they did a study, and they got me involved in the publication, but it was ultimately their study. And it showed that in that case, they gave a polyphenol-rich supplement, but I suppose the same would apply to polyphenol-rich foods, that women with symptoms have if they increase their polyphenol intake, they have a reduced risk of arthritis and hot flushes and better mood, which doesn't come as a surprise, but we published that. So now when women come back and say, look, I'm really not tolerating this aromatase inhibitor, I want to come off it, is there anything else? We will sit down with the evidence from that study and say, try this first. So we will then point out what they should be eating, exercising, increasing the vitamin D levels, etc., and then come back in a couple of months. And if you still want to try, want to stop the hormones, which might be giving them a sort of 10% reduction in their cancer coming back. So we don't want women to stop it if it's all possible. So we spend a lot of time going through the options, and the nurses who are fantastic in our unit of explaining what foods do what. We have signposters, they're called. We're not nurses, but they're assistants who, after the consultation, will sit down with a patient for another, because we get 5 minutes in a consultation, so they've got 20 minutes. So I'll give them the seed, and then the signposters will sit down and really say, you need to go out and you need to buy this and you need to buy this. And sometimes if they ask for supplements, we point them towards supplements as well, but mainly, as we say, it's to point out dietary changes.
Fantastic. Right. Just before I pass you on to Shiv, just one final question. If you had one little bit of advice for your oncology colleagues from other centres in the UK, what can they do to really help their patients from a lifestyle and microbiome perspective to really enhance their outcomes for cancer therapy?
Think about, when we're all busy, overworked, short of colleagues. So I can understand this. It seems threatening, when you say you're going to have to sit down and talk about ways to improve the microbiome before you start these biologicals. And they'll say, I just don't have time. I said, well, what's going to happen if you don't do that? Those patients, there's going to be a higher percentage coming off treatment. You're going to have to dose reduce, deal with their toxicity. They might even end up in intensive care with lung disease and lung problems. So my advice to them is just emphasize the prehabilitation more, because it does reap benefits to you. You might think it takes more time, but also, patients do listen to doctors. I mean, I'm not bigging ourselves up, but there's a fact that there's research to show that, what doctors say does influence patients a lot. But it doesn't have to be everything. All we need to do is put the seed into their head. and to set up an infrastructure within your department where other people can take the conversation forward. So that could be a nutritionalist, or just, dietitians are changing. They're getting on board with the gut health now. Just to set up, do some work to set up an infrastructure. So every time that patient's in your department, it could be with the chemotherapy nurses, the signposters, the support group, all the emphasis on gut health and exercise, etc., is reinforced. And actually, it doesn't take more time, because, a patient comes to you saying, I'm feeling dreadful with my joint pains and hot flushes, etc. And, they want to have measures with which they can empower themselves. So, but, don't just dismiss it as something I don't have time. Invest in the time and you will reap benefits.
Fantastic. Thank you so much, Rob. That was really, really fascinating. I'm going to pass you over to Shiv now, who's just got a few more questions for you.
Thanks, Sheena.
That was incredible, Rob. I'm really struck by how the landscape has shifted in a relatively short time. I mean, I qualified over 30 years ago, and at that time it was, oncology was just all about chemotherapy, and, quite a lot of cancers had very poor prognosis, and certainly discussing nutrition was not even on the table, because a lot of these patients had terrible nausea and vomiting. And it was this idea that, they could just eat what they wanted, and they just had to, be taken out for cake, and, it didn't matter about the quality of the food, but just the number of different therapies there are, the combinations of therapies, and also this idea that doctors have, I think, sometimes, that either when people have cancer, they, stick to the oncological regimes and it's just about drug therapy, or you have patients who say, I don't want that, and they sort of go on to various, fruit and vegetable diets, and that's kind of very frowned upon in the medical world. And I think it was this sort of dichotomy, whereas now we've got this incredible evidence of this sort of synergy of these lifestyle, nutritional, and modern oncological therapies working together. You talked about that only being relatively recent. Do you think we've got a lot of catching up to do, or what are your thoughts about that? What do your colleagues say?
I think there's been a big shift in the last 5 years, and that's, in oncology terms, that is recent. But I mean, it is there's a lot we can do. I mean, this is not rocket science, telling people to change their diet and lifestyle. This is fairly basic stuff. But it is surprising, when I talk to people. I'll give you another example, which Sheena asked me advice for other people. It was only 18 months ago that we were getting, charities donating goodie bags to our cancer patients. And in the goodie bag was full of sweets. And these people were on chemotherapy. And at the amount of abuse I had of, some nurses, the charities themselves saying, we're only trying to help. I'm saying, sorry, you're not helping, giving people sweet. And it took 6 months. And when I hear, so we've banned them from our unit. I mean, we've changed them. They're now goodie bags with good things in. But when I ask across the country, for example, they're still donating sweets to people on chemotherapy. So, yeah, it's even simple things like that is still going on across the country. And it's the worst thing you can do is give someone who's just been injected with 8 milligrams of dexamethasone for their chemotherapy and get them to suck on a boiled sweet. So, yeah, that is still going on across the country. And I think the emphasis, as I said to Sheena, they're not referring people to exercise programs, which should be routine. Most dietitians are getting on board with the gut health before biologicals. But again, I think that's sporadic. It should be almost, well, I don't like legislating things and saying they can't go on to their treatments without this, because it just adds bureaucracy. But it should be a much higher priority that, instead of prescribing it should be prescribed on the computer, and there should be a box saying, has this person been counselled for gut health? And there should be more ways to police that actually happens, because it is, I would say across the country is less than 50% would be counselled for gut health before going on to treatment.
Yeah. I mean, I was really struck by what you were saying about explaining to your patients and with urgency about how much of a difference it could make, because I think sometimes we've perhaps taught patients over the years that these lifestyle medicine modalities like nutrition and sleep and physical activity are a bit of a kind of, a weak, help that might be quite nice for them to do, to sleep well and to do a bit of exercise. But you're talking about sort of big percentage changes in outcomes, and that are, similar to the sort of changes that you're talking about with some of the medications that are added. And I don't know if doctor colleagues actually appreciate how the wealth of evidence there is about these modalities now.
It does surprise me, especially when I suddenly, take over colleagues' patients and I ask them what they've been told, and often it's nothing. And you give talks in front of your colleagues in university hospitals, and they sort of smirk and say, "Oh, we don't exercise much," and sort of make light of it. And I'm saying, we're actually talking about an intervention which will, improve your chance of response by 30%, reduce your chance of relapse by 30%, will make you feel better, reduce chronic problems related to ongoing cancer treatments, such as heart disease, diabetes, etc. So, these are serious things, and it's not being taken seriously by many people. But as I said, it is changing. The fact that we got it into nice policy helped, but we've stopped being peer reviewed by NICE or sort of the equivalent committee. So maybe we should just emphasize that more often, sort of a carrot and stick type way of managing people.
I mean, it's incredibly empowering what you're telling patients, because quite often the process has been one of, I'm very sorry to tell you the news, there's nothing you can do, the oncologist will sort you out. And that's very disempowering for patients now to realise that by, doing these things which are healthful and joyful, getting sleep, connecting with people, eating wonderful food, and being physically active can make a profound difference to their progress and, prehabilitating before they have their treatment and recovering afterwards. Because, of course, as you said, all these chemotherapy and other biological therapies have a profound negative impact on the gut microbiome as well. I mean, you talked about prehabilitation. What about the other side of treatment? Is there a kind of rehabilitation thing, the other side, or what advice do you give there?
Just picking up on your point of empowerment, I had a patient who actually was managed mainly in London, and he'd been through all the, he'd been to the Marsden, he'd been to Harley Street, he'd been to all the sort of usual places. And he came to me just for medical advice, but also some lifestyle advice. And he said his last, I think it was one of the surgeons who said to him, "There's nothing you can do. Your disease is, is either going to respond to treatment or not." And he said that one sentence was the worst thing he was told in his whole pathway, because to be told, he was a barrister in the city, actually, so a big high flyer, and to be told there's nothing you can do to help yourself, he said, sounded the most depressing thing, because he was a person who needed to be in control. And then, after an hour of going through fairly common sense things, which you've talked about in your podcast, he said, "Now, this has just given me a focus now. I get up in the morning and I'm going to, help fight my cancer with these strategies." Now, it may not make a difference in that particular person's cancer, but it certainly makes him feel better. And that's the most important. So, so thank you for highlighting that. In terms of prehab, I mean, fair play to the Macmillan and the Royal College of Anaesthetists. There is a big prehabilitation program going on now, mainly looking at exercise before surgery. I think it should be expanded to diet before biologicals, but, at least this process has started. But most of the survivorship, as it's often called, is where someone's been through their chemotherapy. They might still be on biologicals or hormones, but they've come off the most intense part of their treatment. And that's the time we try to concentrate on the lifestyle measures, because that's often, often patients feel a bit vulnerable. They finish, they've been coming every week for 6 months, and now suddenly they might only get a 3-month or a 4-month follow-up. And that's the time they feel a bit vulnerable and deserted. So that's when we often refer to an exercise program and try to get them to look at resources. And, things like concentrate on gut health is certainly a high part of that. Unfortunately, we don't have the resources at the moment. I'd like to prioritize that and see them more often in that period, but we often have to discharge them. So that's where a bit more work needs to be done. But referring them to a nutritionist or an exercise program is probably the best we can do at that stage.
Yeah, I mean, I think the resource issue is definitely a problem, because the NHS, is very used to giving resources for medications and drugs, and less for all these lifestyle medicine modalities, because you need brilliant experts, dietitians, nutritionists, physical activity experts to run these programs, and all that does cost money, but it doesn't seem to be something that's allocated for. Is that something that you're finding?
Yeah. Well, I mean, fortunately, I do have a private practice as well, and I work very heavily with Genesis Care, which is Britain's largest private provider of radiotherapy. And I worked with Penny Bron to set up their rehabilitation program. So all patients, if they're lucky enough to be privately insured, who go to Genesis Care, the first thing they get when they get to the unit, they get met by an exercise professional. They get put into an exercise program. That professional also gives some dietary advice, and also they do some holistic treatments such as acupuncture, massage, reflexology, and things. So, and they love it. They even people who do a lot of exercise, or people who hardly any exercise, they all say they get a benefit. The feedback is tremendous. So if they come for their radiotherapy, they go to the gym first. They do a 20-minute workout. They then go onto the machine. We know that exercise will reduce the toxicity of radiotherapy. And then they're given a program for 6 weeks afterwards. So it's usually a 12-week program, but starts before treatment. Now, that would be great if we could do that model, which works really well for Genesis. Okay, it does cost them more money, but they get benefits. People have less toxicities. They get through the treatment much better. They're happier. Imagine if we could expand that across the whole NHS.
Yeah, absolutely. And I suppose what I would say to, patients maybe who are listening and thinking, well, that's okay if you've got private insurance, is be empowered. All these things you're talking about are available to all of us. This nutrition is available to all of us. This, parks, getting out there, gyms, or, going for walks with friends, sleeping well, and connecting with people. All this is available and free to all of us. It would be lovely if it was packaged like that. But I just want people to feel empowered and hopeful and, confident that they can look at some of these programs. And, we'll be putting some links to things, and the British Society of Lifestyle Medicine is a good place to look at as well, because all these things are not sort of expensive drugs that you couldn't possibly get hold of. These are things that are available to everyone, kind of free of charge. Would you agree with that?
I would agree. And, you can now, I think it's pretty much universal across the country. You can go to your GP and ask for a referral. Correct me if I'm wrong, Sheena. You can ask for an exercise referral for 12 weeks with cancer as one of your indications for the referral. So, it's previously was available for bad backs and cardiac rehab, but it's now actually available for cancer. So you can ask your GP. And there are most cancer units will have an information office or officer who can link in with walking groups, local Pilates group, yoga, many of which are very, very cheap. But I have to say, what the private unit does. It's raining outside, you're feeling a bit tired and miserable for your treatment. When you've got someone with a smiley face meeting you as you walk through the door and saying, come this way and come into the gym and we do a 20-minute program, that works very, very well. And sometimes patients need that extra supervision and extra encouragement, which you only get with a formal program. But you are entirely right. There's a lot out there, but you just need to be, a little bit more self-motivated to link into them.
Well, hopefully these sort of discussions that we're having today and all of us pushing for this on the NHS will, give it that energy, because it's incredibly important. But Dr. Rob, just before we kind of wrap up, I just wanted, normally what we do on the podcast is talk briefly about a research paper. So we do this because we think it's really important for people listening, whether they're medical or non-medical, to be in touch with the fact that all this is evidence-based, and we can only get the evidence if the research is done, and we need people like you to do it. And I think you've highlighted today some of the incredible research you've done, but also how slow and laborious and complex it all is. So the paper we're going to mention today is by Dr. Rese, and it's called Sustained Minimal Residual Disease Negativity in Multiple Myeloma is Associated with Stool Butyrate and Healthier Plant-Based Diets. It was published in Clinical Cancer Research 2022. Anyone listening who thinks I did not understand any of those words, do not worry. So very, very briefly, multiple myeloma is a cancer of the blood cells. Don't worry if you don't know any medicine, just stick with me. Specifically your white blood cells that produce antibodies. We know that these antibodies are an important part of our immune system and how we detect and fight infections like COVID-19 or other bacterial infections. So just bear with me. You've got these blood cells, and some of them can turn cancerous and form this thing called multiple myeloma. Now, it's not that common. It's the 19th most common cancer in the UK. I think it accounts for about 2% of all new cancer cases. But we're sort of thinking in the UK, it's approximately 6,000 new cases per annum, and I think that's something like 16 per day. Now, myeloma, when I started doing medicine, was sort of a devastating diagnosis, but the survival rates have massively, I think they quadrupled in the last 30 years or so. So almost 1 in 3 people diagnosed with multiple myeloma in England survive over 10 years. We don't know a lot about the etiology, but there's lots of concerns about metabolic risk factors. And you alluded to this, Dr. Rob, about obesity and diabetes and gut health. All acting together. Things don't work separately in the human body. It's all a big network of interconnecting systems. Now, the interesting thing I wanted to sort of say about multiple myeloma is a spectrum of diseases. So I have patients who just had a blood test and were found to have a few abnormalities and were diagnosed with something called MGUS, which is monoclonal gammopathy of undetermined significance. Now, this is not multiple myeloma, and these patients are told not to worry, but they're also told that they've got a 1 to 2% chance of it swinging over to full-blown multiple myeloma, and there's nothing they can do. They just have to watch and wait. Some of these then progress further into something called smouldering, and that is, they've got about a 10% chance of transferring into multiple myeloma. Now, it's really complex for patients because they're told they have this not cancer, but it's a precancerous condition. They're not to worry about it. No, there's nothing they can do. If it does turn into multiple myeloma, the treatment regimes have improved dramatically over the last 20 years, but it's still considered not curable. It's sort of put into remission, and then you're put on a drug that keeps you in remission. Now, the interesting thing about this paper is the author. So one of the co-authors, Dr. Rese, I just find it really interesting because she's an oncologist and hematologist who was studying hard. And in 2016, she got diagnosed with another hematological cancer, Hodgkin's lymphoma, and needed chemotherapy. And I suppose I find this interesting, and I hope listeners do as well, because it's easy to think that doctors are on one side of the fence and researchers and patients are on the other side. But of course, we're all humans, and, all doctors, all researchers are patients as well, or we have loved ones with diseases. So we're all kind of trying to find our way through this. And it wasn't till she had that done and had that chemotherapy that she started looking at nutrition. only because relatives were saying, oh, you need to eat more healthily. And she found it a bit irritating because she said, I'm a doctor, I know what I'm doing. It's all about the drugs. And she was pretty blown away by this large body of evidence on nutrition and health and cancer that was not taught at medical school, and still isn't taught really as well. And she started reading into it, and it wasn't just interesting stuff from wellbeing experts. It was really evidence-based, incredible studies done at the top universities. And I suppose it's now steered her research on multiple myeloma, which she studies now, into nutrition and the gut microbiome, and particularly how people's risk of cancer is increased if they've got metabolic disease and diabetes or obesity. So it's just quite interesting that she's looking at this now, this whole area of nutritional oncology. And just briefly, one study, again, it's very small studies. You don't get a lot of funding, as I'm sure you know, Dr. Rob, for these studies. It's not involving drugs. So she took about 70 people who were on this remission therapy, this lenalidomide, and she looked at them prospectively. It wasn't a randomized control study. It was just an observational study. So she looked at their stool and she looked at their butyrate-producing microbes. And anyone who listens to this podcast knows that on the whole, the microbes that produce butyrate is beneficial for many reasons, which Dr. Rob has explained today. It increases, it helps your immune system, reduces your inflammation, and really bolsters your gut barrier and reduces leaky gut. So they looked at that, and they also assessed their diet, looking at their healthy index, their flavonoid nutrient content, and how healthy their diet was. And they found a really clear correlation between people with a high plant-based index, had a high diversity of gut microbiome, a lot of butyrate production, a lot of butyrate in the stool. And they found that this group of people were far more likely to remain in multiple myeloma remission on this therapy they were on, compared to people who had a less healthful diet. Now, obviously, that's just correlation, but she's now going on to sort of look at other studies. And interestingly, they're starting to do things like sort of 24 weeks of intensive nutritional therapy. And I suppose in the sort of thing that you're talking about, which is intensive coaching, physical activity and nutrition coaching. And I suppose I'm just, first of all, Dr. Rob, you're a pioneer in all this. This is a kind of brilliant young doctor in New York, but you've been doing all this sort of thing for years. But they're finding that the biomarkers of people are reducing weight, reducing their HbA1cs, reducing their LDL levels, their insulin levels, their C-reactive proteins. And for anyone who's not sure what I'm talking about, these are all biomarkers that really positively influence your chance of getting cancer in the first place, but also your response to treatment and your recovery afterwards and your chance of staying in remission. So it's kind of, quite exciting and mirrors a lot of the studies that you're doing. And I just wondered, is that happening? You mentioned these studies in Cambridge. Is there a lot of studies on just nutrition rather than probiotics?
Oh, lots. I mean, I wrote a paper a couple of years ago looking at the benefits of phytochemicals and probiotics for cancer, and not only how they benefit, but the evidence already out there. And there's lots and lots and lots and lots of studies to show that people who have high phytochemical or polyphenol-rich diets have a lower risk of cancer, better response to cancer treatment, and lower relapse rates. So, including breast cancer. So, that sort of correlative data is very well established. And this paper is great because it's a bit more scientific, because they're looking at butyrate containing bacteria in the stool and flavonoid intake. So it's a little bit more scientific. So it just enhances the fact that you can help yourself through diet. Where the next phase is now is to try to do interventions which will, we can do exercise interventions, but most of the data on exercise is as you say, phase 2, or you correlate the number of people exercising against people who don't, and you see if their outcomes change. But there's lots of other factors which affect that. But in terms of diet, is to do an intervention. So that's why we did the POMI-T study back in 2013, where we gave people very high doses of polyphenols, which you wouldn't normally get in a diet, and it showed an impact. That's why we gave probiotics during the COVID study, because it showed it had an impact, and that's why we're doing the current study, because the trouble with phase 2 or correlative data, it could be that people who eat a lot of flavonoids, also exercise, and they don't smoke and they don't eat sugar. So there's too many conflicting factors. You need to know for sure whether it's, say, the phytochemicals. And then once we've got that data, so hopefully with the Your Phyto study, which is just starting, if we do get a correlation, then you can look at, well, okay, hang on, we just gave a generic lactobacillus, albeit good quality probiotic, but there's 5 different lactobacillus. Maybe we could then we could home in to see which bacteria has the best effect with people with myeloma. So if you looked at the landscape in the next 5 years, hopefully we'll be doing specific microbiome signatures or gut health signatures, and we'll be able to use different dietary techniques for different patients, so individualizing it. But all this is exciting, and the paper you highlighted just is an excellent start. But now we need to say, well, I've got myeloma, what can I do more exactly to help me as an individual?
So for those people who are listening and thinking, okay, so we're going to wait for these studies, because that sometimes does happen when we review papers. There's always a reason to do more studies and wait and see what happens. But would you agree that there's enough evidence pointing in the right direction for people to feel empowered and confident to really take a close look at their diet, their intake of whole grains and fibre and beans and fruit and veg, and activity, and that will lightly, we can't say definitely, but certainly make them feel better, but it's likely to really improve their odds?
Well, I think the evidence for that is 100% already confirmed. So, and it should be part of routine management. So all the things you just mentioned, things which improve your gut health, physical activity. We didn't really mention vitamin D, improving your vitamin D levels. But of course, if you have better gut health, your vitamin D level normally goes up. So all those things are 100% established. That's not without any doubt at all. What is less confirmed would be, should you take specific nutritional interventions, such as supplements? We know there's evidence for prostate cancer. We know there's evidence that it can help some symptoms with menopause and side effects of hormones for breast cancer. But, before we go on to have, specific nutritional interventions, we need more research along those lines.
Dr. Rob, absolutely. I'm gobsmacked and excited and delighted by everything you've said. I'm going to hand you over to Dr. Sheena, but thank you so much, and thank you for all your incredible work into lifestyle medicine and oncology and the gut microbiome, and carrying on doing this stuff. And I can tell that you're passionate and feel it's incredibly important. And I think people like you are just changing the landscape. So thank you.
Well, thank you for your very kind comments. But it's a team effort, isn't it, between everyone involved in the care of patients, including organisations like yourselves and the patients themselves, relatives. So, I don't think anyone can take credit for any of this individually.
Lovely. Well, I just want to thank you as well. That has been a really enlightening conversation. I've learned lots, and it really, I feel it's more empowering for me as a GP to hear you state how strong this evidence is for us to take that on board as clinicians. And I hope there's lots of clinicians listening to this, because we all need to work together, because these sort of interventions are so important for our patients. And if we start to use them more widely, our patients are the ones that will benefit. And, with so many people affected by cancer, that's going to be a massive impact. So thank you so much. I've really enjoyed the conversation. And I look forward to hopefully having you back on our podcast one day again, when you can tell us the results of your latest research. So thanks again, Rob.
Thank you. And I like the comment about working together. I think that's really important, that the GPs, the doctors, all the support staff need to be working as a team to be helping patients. So thanks for that final comment and to have me on the show.
Cheers. All right. Goodbye.
Thank you so much for listening to this episode of Microbiome Medics podcast. We really hope you enjoyed the content and we welcome your feedback. We'd love to hear any suggestions you might have for microbiome topics that you'd like us to cover. And we also appreciate listeners' questions and will endeavour to answer them in the next podcast.
So if you want to progress this learning further, look at the Gut Microbiome for Clinicians. It's an online course on bslm.org.uk, which will take you on a much deeper dive into the gut microbiome.